All right, let's jump right into this explainer. Think of this as your personal, high-stakes handbook for becoming a medical detective. Because in clinical medicine, literally every single body fluid is a potential crime scene. And every biochemical marker, that's a vital clue just waiting to be uncovered. Whether we're talking about fluid from the brain, the lungs, the abdomen, or the joints, knowing how to actually read these biological signatures can, no joke, mean the difference between life and death for your patient. So we're going to decode the principles, the interpretations, and those high-yield diagnostic pathways that'll help you solve these medical mysteries. Now, what's really wild here is the sheer scale of the hidden threat we face before the analysis even begins. Get this, up to 70% of diagnostic errors happen in the pre-analytical phase. Yep, before the lab even touches the sample. You see, body fluids are way more sensitive than standard serum because they degrade incredibly fast once they leave the body. It's like a ticking clock. If you mishandle the evidence at the scene, well, your entire investigation is basically compromised before it even starts. So the crucial point here is that to avoid these massive pre-analytical errors, you absolutely have to follow this standard 3-2 protocol to lock down that biological evidence. Tube 1 uses fluoride to block glycolysis. Basically, it stops the cells in the fluid from eating the glucose, which preserves the actual metabolic levels. Tube 2, that uses plain or heparin to avoid crystal artifacts that would totally mess up your protein analysis. And tube 3 uses EDTA to prevent coagulation, keeping the cells pristine so you can get an accurate microscopic count. Oh, and here's a universal clinical rule you can't ever forget. Always order a simultaneous venous blood draw with any fluid tap. I mean, you really can't interpret fluid glucose or protein without knowing what the patient's baseline blood levels were at that exact same moment, right? Moving on to Case 1, Neurological Mysteries, Cracking the CSF Code. Okay, so these are our culprit profiles when we're dealing with meningitis. Now, normal cerebrospinal fluid is clear and colorless. It basically looks just like water. But when pathogens invade, that biochemical profile shifts drastically. If you tap the spine and the fluid comes out turbid or purulent, and the lab shows a plunging glucose ratio, we're talking below 0.4, alongside a really high lactate level from all that anaerobic bacterial metabolism, you're looking at a pyogenic bacterial attack. But on the flip side, if you see this unique fibrinous cobweb clot forming in the tube with a critically depressed chloride level, your villain is tuberculosis. And then there's viral meningitis, which often leaves the fluid clear with normal glucose and lactate. It's definitely the stealthier, aseptic culprit of the bunch. Sometimes, though, the mystery isn't an infection at all. It's blood. If you pull bloody CSF, you're faced with a classic whodunit. Did your needle just nick a vessel on the way in, causing a traumatic tap? Or does the patient actually have a true life-threatening subarachnoid hemorrhage? To solve this, you got to look at your sequential tubes. If the blood clears up from tube 1 to tube 3, you're in the clear. It's a traumatic tap. But if it is uniformly bloody across all the tubes, you spin it down in a centrifuge. If the fluid sitting on top, the supernatant, is pristine and water clear, yep, you caused the bleed. But if that supernatant has a yellow xanthochromic tint, you have definitive proof of a true brain bleed. That yellow color is literally the biological footprint of oxyhemoglobin breaking down into bilirubin over several hours inside the skull.
All right, Case 2, Pathological Fluid Shifts, Ascites and the SAG Interrogation.
So go ahead and forget those outdated transudate versus exudate labels for the abdomen. Modern medicine relies on the serum ascites albumin gradient, or SAG for short. The calculation is brilliantly simple. Take the serum albumin level from that simultaneous blood draw we talked about, and just subtract the ascites fluid albumin level. But try to think of SAG as more than just math. It's actually a really deep physical concept. We're essentially measuring whether fluid is leaking into the belly because a high-pressure pipe is bursting, or because the biological sponge itself is broken, inflamed, and weeping proteins. Depending on which side of the gradient your evidence falls, you're looking at a completely different lineup of suspects. A high SAG, meaning 11 grams per liter or more, points directly to portal hypertension with over 97% accuracy. This is driven by pure hydrostatic pressure. It's that bursting pipe scenario I mentioned, pointing to culprits like liver cirrhosis or congestive heart failure. Conversely, a low SAG, so anything under 11, indicates normal pressure but a highly permeable, leaky membrane. This is your inflammatory or neoplastic weeping, the broken sponge. In this case, you have to hunt down local pathologies like peritoneal tuberculosis, which is a massive challenge globally, or malignancies like carcinomatosis. Let's move up to Case 3, the thoracic cavity, pleural and pericardial effusions. When fluid invades those tight, unforgiving spaces around the lungs and heart, it can trigger a really rapid, lethal collapse. So before we can safely treat a patient who is struggling to breathe, we face this critical diagnostic cliffhanger. How do we definitively prove if a pleural effusion is just a systemic backup of water, or if the lung's protective membrane itself is structurally compromised, damaged, and actively leaking proteins right into the chest cavity? Well, the solution is Light's criteria. It's this incredibly elegant three-step biochemical trap. First, we check the ratio of fluid protein to serum protein, looking for anything over 0.5. Next, we check the LDH ratio, looking for anything over 0.6. And finally, we check if the absolute fluid LDH exceeds 2/3 of the upper limit of normal for serum. Now here is the absolute genius of Light's criteria. It operates on an OR logic. If your fluid meets just one, literally just one of these three parameters, you can confidently declare the fluid in exudate, meaning the membrane is actively damaged. This simple rule gives us an outstanding 98% composite diagnostic sensitivity. To put that into perspective, just look at what we're dealing with here. You can clearly see a severe left-sided pleural effusion with that classic sweeping meniscus line. That massive volume of fluid is actively crushing the patient's lung cavity. By tapping that fluid and applying Light's criteria, we aren't just guessing anymore. We biochemically prove whether we need to treat them for systemic heart failure, or if we need to start hunting for a local pneumonia, tuberculosis, or even lung cancer that's causing an exudative leak. And honestly, the stakes get even higher when we look at the fluid surrounding the heart. Physiologically, the pericardial sac only holds a tiny amount of fluid, maybe 15 to 50 milliliters, just enough for a little lubrication. But if a fast-acting infection or malignancy causes a rapid mechanical volume expansion, it physically crushes the heart. The ventricles just can't fill with blood, which induces an acute hemodynamic collapse known as cardiac tamponade. This is a terrifying life-or-death emergency. It requires an immediate, needle-guided tap, a pericardiocentesis, under strict echocardiographic monitoring, just to safely drain the fluid and track down the biochemical culprit. Finally, Case 4, joint investigations, arthrocentesis, and the ultimate lie detector. Heading all the way out to the body's extremities, when you perform an arthrocentesis, which is tapping a swollen joint, you're basically sorting the fluid into one of 4 distinct groups. Normal fluid is clear and viscous. Group 2 is non-inflammatory, like what you'd see in osteoarthritis. Group 3 is inflammatory, pointing to things like gout or rheumatoid arthritis. But listen up, because here is the massive diagnostic alert you need to watch out for. If you pull joint fluid and the lab returns a white blood cell count exploding over 50,000, with more than 75% of those being aggressive neutrophils, and the glucose is totally depleted, you have a septic joint. This is a straight-up surgical emergency. Bacteria are actively destroying the joint cartilage as we speak, and it requires rapid, aggressive drainage to prevent permanent, total enzymatic destruction of that joint. Now, let's say your joint fluid falls into that Group 3 inflammatory category. You still need to know exactly what is causing the patient's immense pain, and this is where polarized light microscopy acts as your ultimate lie detector. By shining specialized light through the fluid, the crystals literally light up and confess their true identity. Monosodium urate crystals, the real culprits behind gout, they'll show up as sharp, needle-shaped structures that glow a brilliant yellow when parallel to the compensator axis, thanks to strong negative birefringence. On the other hand, calcium pyrophosphate crystals, which cause pseudogout, appear as blunt, rhomboidal shapes glowing a distinct blue. Literally, one look through that polarized lens and bam, the mystery is instantly solved. As we close the case file on these biochemical analyses, I want to leave you with a final, provocative thought. We've seen how fluid from the spine, the abdomen, the lungs, and the joints can beautifully map out a patient's hidden pathologies. But think back to our very first rule. Without comparing that fluid to the systemic baseline, you are investigating completely in the dark. So what critical diagnostic clue might you totally misinterpret in your next patient if you rush the tap and skip that foundational, simultaneous venous blood draw? Keep your evidence pristine, trust your gradients, and whatever you do, never stop investigating.